So it's July, and that's our welcoming of our new interns and people coming back from research. And Dr. Brooks reached out to me to give a didactics grand rounds as part of the new year, and focusing on EVDs and decompressive craniectomies and ICP management. So I'll be talking probably 20-30 minutes, and then we'll do some EVD and demonstrations. We'll do some positioning for decompressive craniectomy and mark out burr holes for decompressive craniectomy. So this will be mainly focused on severe traumatic brain injury. The same incision can be used for decompressive craniectomy for stroke and subdurals, but I'll be mainly talking about severe traumatic brain injury management. I have no disclosures. So our objectives are describe the major parameters of frontal approach external ventricular drain, outline standard precautions against elevated intracranial pressure and traumatic brain injury, as well as stepwise treatment for elevated intracranial pressure, explain the patient positioning, incision, and burr hole locations of a standard decompressive craniectomy, and interpret a postoperative head CT after decompressive craniectomy against standard parameters and goals. So we'll start with a case. A 55-year-old male presents after a motorcycle crash. He was helmeted. The helmet was cracked. He's GCS 6 in the field for EMS. He's brought in by ambulance. GCS 6, eyes closed, not speaking, withdrawing the pain bilaterally on initial trauma evaluation. The CT head is notable for bifrontal traumatic subarachnoid and possible small volume bilateral temporal contusions. No other injuries are identified. What are your initial admission orders and patient instrumentation? What does this person need?
Intubation and ICU monitor.
What else?
Greater than 60.
What else?
Neurosurgery.
Repeat CT head assess for interval connection.
What else?
Central access, daylight.
What else? This is your admission. It's not going to trauma.
What's his blood pressure?
Let's say it's 94/63.
We have access,
What kind of access do we need?
arterial.
Central line is a good idea.
Nutrition.
When do we need to do that by? Yeah. In terms of the first 6 hours, what do we need to do?
This is GCS. At what point we have GCS of 6? What's that? Sure.
I'm Jake said.
Yeah, Jake said it. Intubate for sure.
Debate. Okay.
ED or ICU monitor.
And what else? What else? Up to guess. That's all. That positioning. Want to know what ICP is?
Yeah.
Okay, so at minimum, they need a CMP, CBC with platelets. They need a type and screen. They need coags. Generally, it's a good idea to get serum alcohol level and urine tox. See what else might be on board. We mentioned some of the admission instrumentation. He needs adequate peripheral IVs for resuscitation. He needs a Foley catheter with temp probe. Radial art line was mentioned. We mentioned an EVD or ICP monitor, and then we mentioned that intubation is essential in these patients. And our goal at FiO2 at this point is greater than 100. So where do we place the EVD?
In a situation that doesn't have a, like, lateralizing quality or point or typical got them described up here. You could also go with very safe access points. And if for some reason one of them is not available, there's still away from the challenge with that side.
Does anyone happen to know how Coker defined Coker's point?
Says put a centimeter anterior to the coronal suture in the ventricular area.
Oh. Anyone else have any guesses on how Coker defined his points?
Particular to the frame.
So this I found really interesting going from institution to institution as a med student, is that each institution you would get to would say Coker's point was at a different place. And that was super confusing to me. If you look in the literature for different people trying to define Coker's point, it's often not actually referencing Coker's original papers. The original papers were written in German. They're not really translated. There's not really good specific quotes in the papers to define these points. But what he did was he had this little sort of pseudo stereotactic device that would mount as a band around the head and then define points. And and he said that this point and this point were safe access points to the ventricle. Because we don't use this device anymore, we're all interpolating what he probably meant with this. And so people will say anywhere between 10 and 13 centimeters posterior to the nasion. You'll hear 1.5 all the way to 4 centimeters lateral to the midline. And people will say at the mid-pupillary point. And then approximately I've heard on the coronal suture, ½ centimeter anterior to the coronal suture. This one mentions 1 to 2 centimeters anterior to the coronal suture.
Why is that considered to be safe? What's that?
You're avoiding motor strip.
What else?
Avoiding midline.
Wait a midline. That we said.
You're trying to stay off the sinus, avoid eloquent tissue, relatively. Some people will say that as long as you're going perpendicular to the skull, that there's, pretty much every point leads to the ventricle, but this is a particularly safe way to get there. On the left side, you're worried about Broca's area if you go too far lateral. But on the right, it's less eloquent, of course.
What else is safe about it? I know you guys know a lot of them, you guys know this, or the last bit. For the new junior residents here. This is size and shape of the vegetable here. Some of this, should be the biggest target. So you're more likely to get and be able to get that tactile feedback that you're in this location than in other locations. Eventually, all sorts of weird locations. You'll be like, this is great. This is fantastic. I'm not good at royal plexus. Right.
The venous anatomy can also be favorable, but less likely to,
Or desmotic veins or what's not on this thing. So there's all these many reasons. It's good to learn those reasons because it makes it here to be comfortable. For one, and number two, it helps you later on when you're doing more complicated things. You're going to think, well, these are the ways to turn it up to be targeted.
I borrowed this from one of Elsa's recent notes. It seems to be what people use here. And
When I was a resident, it was fancy can. I had memorized his hand size. Just a joke.
Here's another view. This one is measuring from the glabella. Can anyone tell me what the difference between what the glabella is, what the nasion is, and what the difference is?
So glabella is like the prominence here, between the eyebrows, and the nasion is actually where the sutures come together, which is like the divot at the top of your nose. So the glabella is, if you're measuring, we'll need to do a slightly shorter measurement to end up at the same spot than if you're measuring from the nasion.
Yeah, the glabella, if you have a unibrow, that sort of defines the glabella for you.
I never gonna forget that.
Yeah.
And on this one, they're measuring from the glabella.
What's a good way to estimate where the coronal suture is?
A little bit closer to your line.
Your hairline?
Yeah. No comment.
Fair. Low blow, but I have. Anybody else? Ideas? Feeling this. What's that? Feeling for it? You kind of feel for it. That sometimes works, but sometimes your patients are bigger and scalp, so. What else? Like craniometric points, you can kind of look at somebody, get a rough idea of where it is. Right, so lateral canvas, external obturator meatus, the line between those two. Okay, and then perpendicular to that, the mid, like halfway between those. That will tell you roughly where the coronal suture is. Of course, then you can, as you're doing all this, to make like measure on a tiny head, you realize. What centimeters if I can get that supposed to get this. You got a trouble.
In residency, we did it off the coronal suture, and one mistake that people would make is they would start feeling for the coronal suture in the forehead, and then end up with one of the nuchal attachments, and end up way anterior. So you want to start posterior and move forward if you're trying to feel for that attachment.
I've always found it incredibly hard.
Unless it's in kids, I mean, adults have fat scalps, so.
There's just so many lumps of bumps. I was taught this kind of years ago. use that along with measuring it. So as we get into this, talk about it. Stay safe. Right, carry on.
So have is anyone here familiar with Mystery Science Theater?
Holy man, shit.
Larson, yes, Larson, yes. No. We have the nerdy.
Lars? Yes. Oh, yeah. Okay, all right. He's from Minnesota. Swear.
Lars, can you describe the concept of Mystery Science Theater?
Describe the concept?
Yeah.
I don't know what it is.
Oh my God. Well, it's comedy. It's essentially comedy, right? It's
Yeah.
describing movies in real time. Yeah.
Describe it.
Yes.
On a spaceship rotating outside.
Yes.
They found all the old movies.
So they would be watching a movie and commenting on it at the same time. So we're going to do the same thing. I want you to yell out where you think they're making errors or doing things differently than you do.
A trocar with a protective covering, and an adapter with a cap. The collecting system has 5 components: a pressure scale to mark the level of drainage, a pressure transducer, a drip chamber, catheter tubing to connect the EVD to the collecting system, and a collection bag. After putting on non-sterile gloves, place the patient in the supine position, with the head of the bed angled at 45 degrees. Place the absorbent pad underneath the patient's head. Wash the patient's scalp with soap and water and dry it with the towel. Shave the hair on the right frontal scalp liberally. Use the pen and ruler to mark the EVD entry point on the skull, which is approximately 10 centimeters posterior to the nasion and 3 centimeters to the right of the midline, and corresponds roughly to the mid-pupillary line. This entry point will ensure that the EVD does not injure the superior sagittal sinus or the motor cortex. Mark a linear 3 centimeter incision, centering the mark at the EVD entry point in the skull. Secure the patient's head to the bed with 3-inch silk tape.
Does everyone agree with the 3 centimeter incision?
For those incision length?
Yes.
No, that's a lot.
So yell it out. Yell it out when you disagree. This is Mystery Science Theater.
Well, I was gonna say, in the first part where they talked about the gown and gloves, they forgot to mention you have to have sterile stuff hanging in your field. Which is very common. You guys be in the ICU and there's just like stuff everywhere, so you gotta get that out of the way. And so prepping for that is very helpful. You also generally would want somebody to assist just in case the patient is wiggling around. So that you don't have to break sterile field. So
We usually do not wash hair. We just scrub. We don't do water.
yeah, they
So-
like a little cleanse and then they,
Yeah.
it was kind of backwards, I thought.
They watched the hair,
Clip.
and they tried it, and then they clipped it, I would clip first, and then,
To make it easier, you're gonna clip first. You want to clip a lot because you're trying to tunnel and do all that kind of stuff. So because that's really the reason that we cut so much hair is that we're making a tiny incision with the vertical.
I was about to disagree with keeping the head. A lot of people have a lot of lax skin, and so it can move your point somewhere crazy, so you think, oh, I measured, I did a good job, and then suddenly your point's on midline, because they have, the most redundant scalp in the world. So I don't take people, if they're moving around a lot, they need, they're more meds or somebody to help hold them in position, but I think the tape can really screw you up, but
So you could do old towels or old sheets on either side of the head, like this a little bit. Or, yeah, have somebody helping hold it on either side of the jaw, basically. And, the measurements were off.
Well, as compared to some other, like, folks will put here 11 centimeters.
Yeah. I think there's so much range. That's the hardest part about this, like you were mentioning. Institution you go to, it's kind of like, that's why I mentioned, why do we choose this point in the first place? Not so much like exactly 11 centimeters. It's this region of the brain is state that focus something through it. And that I think is in the end probably the most important thing to learn, not memorizing numbers, but memorizing why those numbers exist, what's the anatomy, what key anatomical landmarks are going to keep you out of trouble. Ventral line, femoral suture, ligament cord, suture, should be good to go.
that's what just agree with the bed being, I had a lot of discrimination. For the bed being like by definition at 45, it has to be the right height and the right angle for you to be able to get in at a right angle. So if Elsa's doing AD or BJ's doing AD, they're not gonna set the bed the same. That's stupid, they'll end up in totally different places in the bed.
Yes.
So you need to, obviously, like head of bed elevate is an ICP thing, we wanna do that, but you wanna be reasonable so that you can actually get a trajectory that will get you through the ventricle, and you're not gonna stab way anterior, way posterior, because the bed position is incorrect.
So that's a key point. You said trajectory. So what is the trajectory?
I mean, you want to be aiming, basically for, I think of it as like the middle of the brain, but what you need an outside landmark to think of, like medial campus and your tragus and kind of the intersection of those points. But looking at the patient, you want to think kind of perpendicular to the skull, and then am I aiming to the center of the brain, which is pretty much.
Yeah, so if you think of the skull like a sphere, try to perpendicular to it, that seems to be the most reasonable kind of way to think about it. And yes, if you're BJ, you need the bed high. You're gonna also a little lower, because otherwise you're gonna spin off.
Yeah.
That's really important. What else about patient positioning? I'm sorry, I'm just gonna go on. Patrick, I'm sorry. You and Mr. Sanitary, those. Everybody. Patient positioning.
I like to put their feet up so they won't slide. Yeah, you gotta boost them all the way up.
Boost them all the way up, right? Because why?
Or slide down.
They'll slide down. What happens once they slide down?
Pain.
What?
Yeah.
It's hard to do, but why is it hard? It's not placing it.
Funneling it.
It's funneling and doing all the rest of the work. Yeah, 'cause they can't work underneath. So you want to try and get them boosted up to the edge of the bed, and then the way that they're talking about is creating a beach chair position so their thighs are supported so they don't slide. Most beds will do that. All of our ICU does. Okay, sorry, carry on. May never get done.
Put on a cap, eye protection, and face mask. Then scrub your hands with soap and water. Then put on the sterile gown and gloves.
The eye protection.
Drape the
I don't
surgical
always
table with the sterile sheet and open the cranial access kit and the EVD kit. Using an antiseptic solution, clean the area around the marked incision site. Or
Yes.
EVD allows cerebrospinal fluid, a
Sorry.
perspective
Otherwise, it'll say over.
liberally, soap and water. Then put on the sterile gown, chuck of the drill, and rotate the chuck clockwise, counterclockwise. Inject the local anesthetic agent table with the sterile sheet and open the cranial access kit.
You get sprayed in the face all the time because you're like looking close at things. And just put on eye protection, just don't get it. And you know, obviously, face protection is not so much protect the patient.
There's a sign of even when removing drains. I've had a drain.
Oh, yeah.
Snap, a JP drain.
Yeah.
This whole snap. Not snap.
Itch in the mouth, and you're like, that's what to do about this.
I don't believe in the retracted, but we'll get there.
Okay. Carrying on.
Kit and the EVD kit. Using an antiseptic solution, clean the area around the marked incision site.
Setting up their tray.
Place a fenestrated drape around the incision site.
So yeah, very good point. We'll get all that stuff set up.
What do you
Inject
think
the
of that
local
drape?
anesthetic agent along the marked site.
Yeah, it's gigantic.
Hold the drill handle and rotate the chuck counterclockwise to open the space for.
So that drape is big. I think you should drape as much as you possibly can. And so a lot of the kits don't have very large drapes, so if you get extra towels, extra sterile sheets, those kind of things can be very helpful because otherwise, you know, that the drain will just kind of flip around and flop around. And, once it gets unsterile, you got to start over and over again. Good. And then when you're draping, you have to figure out a way to, I really like to drape so that it's the midline and some idea of where the Nasion is. So what I like to do actually is put like an EKG pad right in the line so you can palpate that. And then you can also put it. Yeah. Just lateral to just anterior to the external or meatus, you kind of have that landmark and feel that. You can always palpate the lateral canvas. So I mean, obviously, you know, most of the time I do this pretty well. It's when you can't do it very well. That's when you need all that stuff. So I just do it all the same.
Yeah, if you have a towel. So towels can come forward and try and just lay a towel.
Exactly right. Right. So yeah, when you're draping, you can drape that midline out. So there's another good way.
I also noticed they only prepped using one of those CSG lollipops. They didn't do the full betadine prep that we used.
They had done, and then that's actually a second prep. They had first washed and soaked the hair, and then shaved, and then this is second prep that they did.
If we were gonna say like chlorhexidine, would be the preferred, strongly preferred prep.
I was told, usually or hexidine,
If you're just trying to scrub it.
like I
Scrub. Yeah.
scrub betadine
Yeah.
and then or prep it, and
Yeah.
then once I get everything set, I do one more.
Yeah. Betadine, by the way, is bacteriostatic. It's not bactericidal, so it captures the bacteria rise. Yeah, but you can't rub it on. Chloroprep has a persistent bactericidal effect.
As far as draping, I got a challenge in the prep area and the patient's transferring drops. I think it's all sterile place too, as opposed to a little bit on your side.
Yeah, the more you drape, the more you can kind of like manipulate things without sterile. It makes a huge difference in the procedure. A lot of this is preparation. Sarah doesn't believe the retractor. We'll get to
the drill bit. Insert the bit into the chuck of the drill and rotate the chuck clockwise until the bit feels secure. If you choose to use a depth stop, use a hex wrench to loosen the depth stop of the twist drill. Set it at a depth of 20 millimeters and retighten the depth stop. The
Does
use of a
everyone here
depth
use
stop is
the
optional,
depth
and this
stop?
video demonstrates drilling of the skull without a depth stop.
But the new one.
Power, yeah, that's how it was.
Yeah.
Using the scalpel with the number 15 blade, make an incision down to the bone. Secure the scalpel blade and scrape the pericranium using the handle of the scalpel. Use the retractor to hold the edges of skin open.
What do you
Position the twist drill at the center.
What do you think was wrong there?
We usually use like the end of the pickups or put like a little thin piece of gauze down and then scrape the pickups.
I usually scrape with the,
Whatever works.
Strictly picks.
So they said they were doing a 3 centimeter incision, but that's obviously not.
Yeah.
That's why the retractor is a problem in this case.
Yeah.
Usually I make it big enough so the retractor can actually do something, Sarah,
It doesn't,
usually.
it's not a visualization procedure. So if the goal of your retractor is to like see everything, like you're drilling a hole that you're not gonna be able to really visualize the bottom of, all it does is make it longer and then give you a prime opportunity to get your catheter out of the head when you try and pull your retractor out.
Yeah, I always just thought it's like protecting the skin in just so they're not breathed by the.
I've seen this hole, I get the small incision, but it's nice for me to go particular to the skull, pick another way. I mean, when I can
So I don't think there's a wrong or right answer to this. Sarah wants to do it this way. She can do it. No, it needs to. Yeah, I don't see it right.
Injecting like local.
Okay, let's get to the drilling though. First of all, what the stopper? What we need to have that?
Well, we just had these power drills now that are full, so we don't have any twist drills, so I don't think any of the to get the power.
Doesn't work, bring back the hand drill.
I'm joking. But if you go past the depth, you're just making a slightly larger bed trigger. Right? So we're already gonna poke a hole.
Yeah. Which is one-stop shopping.
Yeah, you go to the garage, you done. But so I don't think, I don't feel that strongly that you have depth stop. Of course, the drill shouldn't be extensively long. And then what else about the drilling is important? Are you a senior resident? I'm gonna do more senior resident. What? Is it just a hole or is there something important about it?
It's uniform, coaxial.
You gotta go right direction.
You want the trajectory in the correct.
Yeah, so because it's a smaller hole, your trajectory's off, and it'll keep pushing you off the trajectory. So it's the same exact trajectory as if you're doing past it.
Also, even though they're it's really wrong. Just that drill, but some of them still. So. Like siding this drill, them just straight up.
Right, these tiny little things can deflect you off course. So you need to keep all that in mind as you're working.
These drills are famous for that's pretty like little ledges, like where you finger through.
Oh.
Yeah, the power drill.
And then you're like trying to like a catheter, you're like forced.
Oh.
So you have to put that thing in a few times.
Okay, anybody want to describe how it feels with you? Joyce, she's good. I know Joyce is good at this.
would be, I mean, it's just a feedback feel, like you feel you're going through the outer cortex first, and then once you're in the inner, it's very soft, and then you feel it's hard again. And you just know by feedback that you're through.
That feeling
You
is,
don't
feels
have
like
to,
it's
like-
catching. It
Yes.
feels like it's catching.
The last turn.
It's a cortical bone on the inside, and then it feels in many ways harder to turn the drill. And then at that point, I don't keep pushing forward. I'll kind of kind of keep a neutral position or pull back that the bonding catches. And then drill a little bit more to make sure it's cleared out.
But you don't have this, so these are the worst drills ever. Sorry, I've used like 3 or 4 times.
Yeah.
These are so bad. I don't know
These
what
are
you
the,
said.
you mean the power?
Yeah, the power drill, I mean, they are funneled first. They don't have the same homogeneous thickness throughout.
Yeah.
They stop halfway and you think you're through and you're not through.
Oh, do they have some sort of stop with them?
Yeah.
I
And
think we only got those because it's backwards.
So there's been a supply chain issue,
yeah. So,
but apparently the Codman like kit, I was talking to Alec recently to try to give these, so that way everyone knows how to use the twist drill.
Yeah.
One place like discontinued it, so they're working at other ones. We had the Steps kit for a while.
Yeah.
Because it had a twist drill in,
Yeah.
which is fine, but the kit's not as good, so you're wasting all the other steps.
Yeah, I mean, I know that we got asked about this last year because there was a supply chain problem. That's how this started, but.
When we brought up that we would like to go back to the other drills, we were recommended to do more Hulu because everyone else likes it.
Recommended by who? Oh,
But that's what I'm saying, we asked for the other drills back, we're like, don't not like this product, it doesn't work.
the ref's not the same for both.
I don't know who the other person is. Yeah, I don't know who she.
Was it Codman drill, it was that set drill, I really don't want to set tracks.
But the hand drills, like, keep back once you're, it's also, you know, like twisted side to so you don't plunge.
So you're saying that the hand drill, have we back in
Yeah. You're like it's getting hard to like slow compression. Real.
Oh, we just twist the hub.
Yeah.
Yep.
And it just pulls you in, nice, and that's fortunate.
So they actually. With an intro. Almost I would people at more, it's like holding that still, holding skull. Last, but that you're still not. You have enough, you have those red dots that. That last twist. Oh, think about it. Oh,
You guys should use the mic. Not doing that.
All right, let's keep on going because otherwise.
Drape the surgical table with the sterile chuck of the drill and rotate the chuck clockwise until the bit feels secure. If you choose to use a depth stop, use a hex wrench to loosen the depth stop of the twist drill. Set it at a depth of 20 millimeters and retighten the depth stop. The use of a depth stop is optional, and this video demonstrates drilling of the skull without a depth stop. Using the scalpel with the number 15 blade, make an incision down to the bone. Secure the scalpel blade and scrape the pericranium using the handle of the scalpel. Use the retractor to hold the edges of skin open. Position the twist drill at the center of the incision, perpendicular to the skull. Turn the handle clockwise at a steady pace. You'll encounter resistance as the bit pierces the outer layer of cortical bone. Once the bit enters the cancellous layer of the bone, it will progress smoothly until it reaches the inner layer of cortical bone. At that point, continue to rotate the handle clockwise while applying backward pressure with your non-dominant hand to prevent the drill from plunging. Stop drilling once the drill pierces this inner layer of cortical bone. Remove any loose pieces of bone with the forceps.
You can also irrigate this out.
Pierce the dura at multiple points with the spinal needle.
This was horrifying.
Next, remove the protective caps from the trocar. Advance
Like that stabbing multiple times like really drove me crazy. I use the trocar. Yeah.
the trocar under the inferior aspect of the incision, aiming to emerge from the skin approximately 3 to 5 centimeters lateral and posterior to the incision. Reconnect the protective cap to the sharp end of the trocar. Use a freehand technique to pass the antibiotic-impregnated EVD into the frontal horn of the right lateral ventricle. Aim the stylet toward the contralateral medial canthus in a trajectory perpendicular to the skull. Hold the catheter and stylet at the 8 centimeter mark and slowly advance the catheter through the frontal cortex to a depth of 6.5 centimeters at the outer table of the skull. Withdraw the stylet to check for CSF. Do not advance the stylet more than 6.5 centimeters.
Control that.
Yeah. Andrew's a poop.
Once the catheter is in the correct position, connect the distal end of the catheter to the serrated end of the trocar. Then hold the catheter in place with blunt forceps and pull the trocar so that the distal end of the catheter slides underneath the skin and emerges from the exit wound made by the trocar. To guard against catheter migration, measure and record the depth at which the catheter exits the skin. At the point of exit, secure the catheter to the skin with a purse string suture. Cut the distal end of the catheter close to the trocar. Then attach the adapter and cap to the distal end of the catheter. Remove the retractor and close the incision with a running or continuous suture. Place 2 more sutures to secure the distal catheter to the skin. Finally, connect the catheter to the sterile tubing from the collecting system. Adjust the height of the collecting system so that the pressure transducer is level with the external auditory canal, and then set the transducer to 0. Wait a few seconds for the triphasic intracranial pressure waveform to stabilize, and then record the first consistent reading. This will be the opening intracranial pressure. Set the height of the collecting system to the desired level, which depends on the intracranial.
So in our case, the EVD is placed, the ICP is 9. What next?
Can we just talk about the depth?
Oh, sure.
Referencing. Like how do you, what do you guys think?
So did they say put your hand at 8 and then advance to 6.5 with the bone? That's what
Right.
I heard them say.
Yes.
Okay, I didn't get that was.
Yeah. Okay. At first I thought they said depth of 8, no, but I think they said hand at 8.
We're just measuring beforehand.
Yeah. If your ventricles are massive, you should know your 8
No.
by 3 or 4.
You should know exactly where you should be
So-
in ventricle.
So rather than just like blindly do this, just look at the CT scan and say, this is what we expect.
If you're thinking about shift or
You
things,
don't think
have to
so?
get up in the room.
I don't think it works. I go to 7F phone every single time I take it. Every single.
Because you're not measuring the actual.
Don't have
side.
Say that again?
You're measuring on CT scan.
Yeah, it's only one plane. It's only one.
Yeah, your coronal slice.
And if you go off just a little bit,
So do you look at the CT scan at all?
if they have preserved midline, 7F.
No, there's nothing.
Are you saying for your final depth or
Expect final depth at the bone.
where you're expecting? to get to the depth?
We got it.
Okay. I mean, that's how it does. A lot of people do it. So, curious.
I'm not looking bigger. So,
What about their mention of the opening pressure? Because by then you've lost a bunch of CSF.
Good their style, yeah.
Yeah. So what?
We just drained off 20, I was to go back to 25. I don't know, don't lose much of CSF.
What's another way?
With the,
You just measure from what are we trying to measure? What do we measure as? You do it in centimeters of water. What's zero?
I think it was like
From where?
the trainer.
Estimated.
Yeah, and if the CSF shoots out, you know that it's greater than 20 or.
Higher than like.
Okay, so what are our initial admission parameters for this gentleman? Should be able to rattle them off. And what are your notify physician parameters? What are your physiological?
We're just talking a little louder. Oh, he's got it. Gotta push it, you've got to be closer.
Oh, yeah, CPP greater than 60. CO2, PCO2 should be between 35 and 45. pH should be between 7.35 and 7.45.
What other EVD parameters are you gonna want them to tell you? What ICP do you want them to call it for?
Well, we're going for a CPP goal of greater than 60. Usually, I'll say like notify if sustained above 20 for more than a few minutes.
Exactly, how many, they're not gonna,
Right,
we can't write down more than a.
5 minutes sustained above 20.
I think our consensus here has been 20, sustained greater than 20 for greater than 5 minutes, but I think 25 is the current Brain Trauma Foundation guideline for that number. And then they also want us to, like, if there's a change in the character of it, if the EVD is not functioning, if it's more, all things that might suggest that it's not working appropriately.
So I think the current Brain Trauma Foundation is 23, but I would not go off the Brain Trauma Foundation guidelines because that process has kind of broken down, and there isn't really a current effort to update those. So it's better to go off the ACS TQIP best practices in terms of all these details.
They using the Brain Trauma Foundation's guidance though?
So
Or many of those people left before the ACS.
well, it was the best trip trial and the interpretation of the best trip trial, like the ICP in South America by Randy Chestnut. And because he started coming to the Brain Trauma Foundation guidelines meetings and saying that, oh, we don't even necessarily need a monitor based on the literature, even though I, in Seattle, will never administer TPI without an ICP monitor, that broke down the whole process on that.
Why would that break it down?
Because on
Sorry to editorial that. Seems like important information for everybody to know.
the Brain Trauma Foundation guidelines were very specifically based on level of evidence rather than expert consensus and practice, and whereas the ACS TQIP guidelines are more, or best practices are more based on expert consensus and regular practice. So in terms of initial admission goals, you want pulse ox greater than 95, which is not really our standard in the ICU. You want ICP less than 20. You want serum sodium 135 to 145. We mentioned the PaO2 greater than 100. We want INR less than 1.4. So if they come in coagulopathic, you'll especially see that with large volume like extracranial. If they have something else bleeding, they might develop kind of a TIC picture. You want PaCO2 35 to 45, CPP greater than 60. You want platelets greater than 75, systolic greater than 100, temperature 36 to 38, hemoglobin greater than 7, pH 735 to 745, and glucose can be anywhere from 80 to 180. We do a repeat head CT. It shows evolution of bifrontal bitemporal contusions without midline shift. The ICP 20 hours after admission is now 28. The EVD is clamped. What are our interventions?
What do you call? Don't see phase 2, they say ours is 28.
So, sorry?
I'm asking the juniors, and you're the in-house resident, say who calls you, I speak 28, what do you want me to do? What are you gonna tell them?
If they're not already doing the like ICP interventions, like make sure the head of bed is elevated. You can also give,
What do you have control over? Open
Just read it.
areas.
you open up,
Kinda, yeah.
yeah, I mean, open up the EVD, drain some,
So functionally, when it's clamped, it's just pressure monitored. Having management function of that. That line, but you may want to also make sure that they have it set properly. But how are they supposed to set these? Beers all.
I mean,
They should have changed.
yeah, I mean, make sure that it's calibrated correctly, that it's an accurate reading based on the setup, open.
And how's that? Without even having any electronics attached to it, tell me how it works.
There's you want to make sure that the pressure transducer is level with the tragus. It's usually a level, and then on a string that you can use to confirm that it's at the right level to measure it.
Without a transducer, no transducer, tell me how you do it. Anybody?
When you use the word transducer, what is that supposed to be level with?
So I don't want to talk about the transducer right now. I just want to talk about how we're measuring pressure.
Isn't it just how far up it is? Isn't it just
Okay.
how where the food is?
So what's zero again?
Atmosphere.
Tragus, external outdoor meters, that's zero. Okay, what should be at zero on a ear trough? The zero.
Zero.
So you go to the bedside and you have this adjustment thing and it goes to zero, so that's zero. Now, if you want to measure pressure without a transducer, again, we talked about it earlier, but how,
You can just measure the height of the fluid.
what way it leaks, so. When it actually leaks over the edge, that's the pressure on the inside. Now, you can't get a waveform very effective. That's why we have transducers. So the transducers being the waveform. And so, yeah, you can check all those pieces, want to make sure that those are appropriate. So if zero is below there, so this pressure going to be falsely high or falsely low.
We'll see.
It's easier to go over the hill, right? And then the other way around. So if they have the bed down, they lower the head of the bed. And they didn't change the level of the transducer slash. Have elevated ICP. I'm just teaching you these basics, so like that's what you guys get called about most of the time. Like it doesn't work, don't do this, don't do that, and check all that stuff.
It's also helpful if you're not on the bedside with the patient, or like you and the patient are in some random place like MRI or something like that, you're not necessarily flag on how high is your ICP generally.
That's why I always teach the basics, even though I do fancy stuff too. But that if you don't really understand like the fundamentals, then you won't even. If something breaks down, it won't be. Really important.
One way to check the level of the water column is to raise the EVD setting until you see, like, if it's at 23 and it's still draining, it's obviously greater than 23, but if it's at 16 and you've got some pulsatility, that'll give you some estimate of what the ICP is.
Then after you get. It's worth to make sure that all oftentimes, RT has to come in and make sure that those things are correct, because carrying a ton of CO2 and stuff like that. Maybe even arguing to do all that stuff, or you just leave it. That happen, especially larger patients.
So tier 1 interventions, head of bed elevated, sedation, analgesia, ventricular drainage performed intermittently. You can do repeat CT and neurologic examination to rule out development of a mass lesion. If the ICP remains greater than 20 or 25, you proceed to tier 2. In our case, so the one thing when we're continuously opening an EVD, you lose that waveform and you're only potentially checking it once an hour, and you're losing the potential accuracy of your EVD. So if you're continuously opening, you should place an ICP monitor. and have both in place. That way you can continuously measure ICP and drain. In this patient, the EVD is opened at 15, an ICP monitor is placed, sedation is increased, head of bed is at 30, the ICP initially responds, but then increases again at 28. The patient is febrile at 39.1. What can we do? We're given Tylenol. He's been getting scheduled Tylenol. What? Yes, yeah. So we could do the mannitol 3%, or sorry, 23.5, drain with the EVD, but in patients that are febrile and having ICP issues and not responding to cooling blankets, you can consider placing a femoral IC cath or Zolgar to allow us to control temperature. That can only be placed femoral. It can only be left in 3 to 5 days. Otherwise, you get DVTs and all sorts of issues. So tier 2 interventions, if you're frequently, if you only have an ICP monitor, these should be placed. You can use hyperosmolar therapy, mannitol, or 23.5, or even 3%, should only be given as boluses. It should never ever be given as scheduled, because then you're going to trip yourself up. You can assess cerebral autoregulation. You can start to lower the PA CO2 goal to 30 to 35. You should consider repeat CT imaging, and then neuromuscular paralysis is an option. In this case, we lowered PaCO2 to 32. We increased the respiratory rate to 28. We placed a central Zolgar. The patient temperature is now controlled. The patient receives 3 separate boluses of 23.4 with good response, but each time the response gets more brief with return to previous elevated ICP. Dose of Nimbex is given, but ICP starts to again come up even with the continuous infusion. What are our management options now?
Nice.
What else?
One for surgery, what else? What's the current sedation?
Just propofol.
So, what do you do with the medications? Try.
Like, why would we put them in that bar?
Why do you put them on any medication?
Just like decrease the metabolic demand. The you're on sort of
Agitation initially leads to the weight.
sure, yeah.
And so that would decrease your blood pressure and stress. And you're fighting against it too, but after that, you're still going to sedate and potentially paralyzed for perpetually still going to sort of most things that's what it is. Sure. Sure, but yeah, there's a rebound effect. What's happening when we have the point? Initially, what's that?
What else is it?
Yes, but what happens? What do you think happens? What's that?
Decreasing cerebral.
Okay. Why? Why would we? Any period. That's bad. But as Dr. Sadler said, what, as an intervention to get to something else, to stabilize that, but not long-term thing. But then after you've done this for a while, what happens? We get vasoconstriction, you know, bring in CSF and blood, so you have less blood in the sinus. Bring in a period. You get compensatory vasodilation. So you can't manage it long-term with that strategy.
And the guidepost tends to be PaCO2 less than 30 for more than 10 minutes, 20 minutes. It's bad. So if you're rushing into surgery, blowing down CO2 is okay, but if you're doing that for an extended period of time, stroke them out.
This is a very different discussion than skull-based surgery. We're utilizing that tool to help us get a little bit more space while we're doing the operation.
If all else fails, hypothermia is an option, but it's considered to be kind of a last ditch option. So the trauma craniotomy, craniectomy, I'll tell you that my principle is that it's one incision every time. That you don't size the incision for the pathology. If you have a convexity subdural acute, you use the same incision every time. If you're doing decompressive craniectomy, if you're doing craniectomy for stroke decompression, use the same incision. And the key parameters is this 12 centimeters vertical by 15 centimeters lateral. That's not an easy number to reach. So it's a large reverse question mark incision made starting 1 centimeter anterior to the tragus at the root of the zygoma, coursing just superior to the pinna and extending posteriorly over the parietal bossing, then carried forward linearly to the hairline. You take a myocutaneous flap, expose the keyhole in the root of the zygoma. Burr holes are placed to enable a large craniotomy. And your goal is to decompress the anterior middle fossa floor.
Pause first. Positioning.
Oh, I'm going to cover that.
You're going to cover that.
Do your point about the incision and think about putting the incision. Just bring this. I bring it right straight.
Yes.
Just leave it at large. That will become just kind of similar. You didn't know where. Whatever. Didn't watch the brain parts. You know, forward. Stay on. That. So, preference. Yeah.
Right, yeah, essentially it has a lot to do with positioning. Just the posterior part is usually the hardest. Right.
Yeah.
Yeah.
One principle for decompressive craniectomy is like go big or go home. There's no half measures here. So your standard size 15 by 12 for an adult size head. Your limits are the sagittal sinus, the transverse sinus, which is really hard to get to. The frontal sinus, I've only seen one frontal sinus violation. As long as you're getting to the Whittle's peak and then taking that linearly down to the keyhole, it's very hard to get to the frontal sinus. But I did take care of a patient that did have a frontal sinus injury violation, decompressive craniectomy, and the middle fossa floor. You're always sacrificing bone before you ever sacrifice brain. So you always want to think about, can I make this craniectomy bigger to preserve brain? Because in terms of the long-term outcomes of these patients, one of the main complaints is not motor deficits, not speech deficits, it's cognitive deficits. And if you leave them with as much brain, as much functional brain as possible at the end of this surgery, they're going to be in better shape than if you potentially reset the brain or things like that.
What's the external landmark for the middle? Just think to yourself.
I was zygoma.
Yeah. That's what you want to have, you want to be exposed down to.
And you really take that one. You rarely actually get that. Yeah. So it's really, yeah. That's. So, but,
Yeah, you're trying to avoid fungal herniation. That's what that.
well,
That part of decompression.
I shaved the entire operative side as well as 4 to 5 centimeters from midline on the opposite side. I use a large shoulder bump. I approximate using the patient's thigh for the shoulder bump. I use the horseshoe head holder. I've seen people pin for this. I don't know why. And the patient nose should be parallel to the floor, and you should be able to easily palpate the inion. If you're not able to palpate the inion, you're not going to be able to take it all the way back.
And you'll have trouble getting drains and stuff out.
You want to identify and mark landmarks. So
Horseshoe, obviously ideal. If you don't have a horseshoe, like you're stuff, you just like buttress things up so you have space. Come up with a plan that exposes that.
You want to mark out the Nazian and Inian and draw a line between them. Like Dr. Stadler, my superior portion of the incision is along the midline. You want to start the incision curve approximately 4 centimeters posterior to the pinna. You want to come just inside or along the lambdoid suture. Here, I've noticed people do kind of small incisions and small craniectomies, so you might get some yelling from the attending if you actually do this. But for me, this is how I do the case.
So can I make a couple comments there? That I think that's great. Typically for prep, anytime prep, just so you don't worry about catching fire later if you're in a hurry. And although this is a rare occurrence, if they like skull-based fractures and stuff, they probably would prep on the neck. They have a someone that coming from the middle fossa, something that you might have to bleed externally. That doesn't happen at all.
Intraoperative fish hook retraction of my muscular cutaneous flap and remaining temporalis. So here and here, you can, if you draw that incision on midline, you should hopefully be able to identify the sagittal suture visually and stay 3 to 4 centimeters off of it. I draw out my burr holes with Bovie. I prefer more bore holes than less. Middle fossa floor, posterior temporal, posterior superior parietal, anterior superior frontal, and keyhole. I always make my craniectomy at least 1 centimeter off the incision, not directly under, because that makes your cranioplasty much easier. if you're not opening directly over your your bone. You always want to direct your keyhole, burr hole, posterior, not anterior. Don't do a McCarty here. You can expect resistance connecting the keyhole to the metatarsal floor from the sphenoid wing. You can swing the craniotome or switch to a bare router bit. I always do my superior cuts last because that's your most dangerous cut, and that's where you can have the most bleeding and can be the most traumatic. In terms of bleeding, you can encounter bleeding from venous legs, dural channels, superiorly. You might encounter bleeding from the middle meningeal or the sphenoid bone. You might have an inadvertent sinus violation or an unexpected or expected prior venous sinus injury or detachment. And when you encounter those are quite traumatic.
Your fancy running shoes.
So the MMA is controlled with bipolar. The sphenoid bone is bleeding with bone wax. But venous bleeding superiorly is controlled with tack-ups. Tack-ups with gel foam reinforcement. You can do a dural flap, so pull the dura over and help cover your sinus violation. It's very hard for long segment, but autologous patch or even direct repair. If you have a big violation and you're getting to there, that probably have the patient sanguinate before you can actually do anything to the host.
So when you have that, sorry, I'm going to ask these guys, but like if you have a sinus injury, what are the first kind of two things?
Flood the field, give with anesthesia.
Then so flood the field, you gave it anesthesia, what else? Sure. With a finger or stop the bleeding. Why are you flooding the field? Dr. Blaylock. What's that?
Air embolus first.
To get the air embolus. Where does the air embolus go to? Or why did they cause the problem? But why was shot? It's the right ventricle. It's like when you have air in system. There's air there and it prevents it from filling into any blood. Okay. Dr. Blaylock, talk about this dural care option. What other tissue? The browse muscle. Is there another tissue that you just haven't left on the bone to use? Fair radium, so you harvest that away from the browse lab. The answer is yes, of course you can. You just have to find the layer and just take it off and use it. Just think. It's just a little harder because everything's kind of shifting stuff. That browse matchup. Benny and I did a case like this about an hour ago. Where a motorcyclist, unhelmeted motorcyclist, got a sad sinus injury, had a huge epidural. Look at this. Yeah. Yeah, we already started with blood everywhere. And he's like, I had to figure on it. Yes, it was a big problem because he tore the sinus in many spots.
So this is where having a system. System.
Yeah,
It's
Or potentially a co-surgeon here.
that. Yeah. For a while.
Yeah, exactly right. Yeah, if somebody's gonna be holding pressure, they may not want to let go because they just don't. Control it.
But it's that help with it.
Well, I just, you know, what did you do? Forget, but generally, you can sew patches without including the sinus. That's kind of the thought process here, that you don't even necessarily have to sew directly. Okay? Only a few stitches have to go directly over the sinus. The rest can be on either side, so you can patch it. So that patch technique works quite well. Essentially, interestingly, that guy survived, was totally fine. Tried to explain how dire his injury was to him after he decided he was going to go back to motorcycling. He said,
For dura opening, prior to opening dura, I place tack up circumferentially, coagulate the entire length of the MMA, complete the, once the bone is off, the ICP is going to come down, so you have some time. Complete the temporal opening of the floor with Flexel. I open dura approximately geometric center and then do pie cuts. Evacuate any hematoma and inspect for bleeding. I don't do a dural closure, and I feel very strongly against doing dural closures in this. So that's my opinion. Closure steps, I place a flat 7 French JP tunnel 3 to 5 centimeters subgaleal off the incisions. Then I place the pie flat cuts back down. I lay down a sheet of separate film to help reduce adhesions with a little slot for your drain. I place a second JP drain tunnel 3 to 5 centimeters. All right, the drains always have to be within bone edges. If you're placing drains past your bone edges, you can get in the brain really easily because you're not able to directly visualize that. I close temporalis muscle back, absorbable galeal sutures, and I run suture for skin. Post-operative, I believe very firmly, leave drains in at least 48 hours, because you don't want to be pulling these drains at the same time as you're really aggressively managing ICP and running into all sorts of trouble. It's so I put it to bulb suction. It's okay if the ICP, if it's sucking CSF, as long as the ICP is not negative. I typically will take it off suction prior to discontinuation. And drain discontinuation is a complex decision about drain output, intracranial pressure, and different available methods for treatment. You always want to check your post-operative CTs after EVD or decompressive craniectomy. You want to inspect the middle fossa floor. You want to check against your 12 by 15 centimeter goal. Here's an example CT. Anyone have an estimate of how big a craniectomy this is? Someone else came in the room and said that this was the biggest incision that they had ever seen in their entire neurosurgery career, even in military combat, and that it was also the biggest craniectomy that they had ever seen. How big do you guys think this actually is?
10 centimeters. 10 centimeters.
Okay. Any other guesses?
I think it's more like 15.
Well, what's
It's 13 by 16. So just about a goal. This is not an easy surgery to do. to do well. You can do this easily and have a small craniectomy, but to do this big and appropriately, it takes some stress. Okay. We're, oh yeah.
One comment. So, talk to somebody about this, but the past, we were at least a handful of times, but he's getting on that side. So, I think because the team keeps changing, it's very rapid. I bet you're gonna find this not really example. I would recommend that you still something that people involved. There are various ways to do it. You guys know how I do it. You can easily either shorten the catheter or roll the catheter. Those CHE dressing, I find incredibly good at keeping on the scalp, and then you can staple them too. And you guys see how I staple beyond the connector so that pulling on it is going to be difficult. The problem is that these diagnostic tablets are very expensive. It's connect easily, they break easily. It doesn't take much. The person doesn't have to be. When they're not fully conscious, that gotta come out every once in a while. So that would be the main issue that really I have with how I see it.
If you guys have any extra time, we can, we've got a skull that we can mark out burr holes on. We have the Hubley and we can do some practice drilling. If you even want to practice positioning, we can do that too.